Hello and welcome to the Dr. MEK Explainer Series.
Thank you. It is very important we are having this discussion today.
Before we proceed, I need to provide a formal medical disclaimer. The information we are discussing today is strictly for educational and public health awareness purposes only.
Right.
It should not, under any circumstances, replace an individualized consultation with your personal healthcare provider.
Exactly. Always consult your physician for medical advice.
Today, our analysis is built entirely upon a recent institutional presentation. It's titled New ACS Colorectal Cancer Screening Guidelines 2026.
Yes, and we are using the source to outline what is, frankly, a critical medical emergency.
We are looking at the rising incidence and the truly fatal consequences of colorectal cancer, or CRC, particularly how it is impacting younger demographics right now.
It is a public health crisis, and our mission today is to dissect these recent American Cancer Society guideline updates. We need to explore how advanced liquid biopsy technologies are being deployed to essentially mitigate this emergency.
And I want to establish the tone right out of the gate here. As physicians, we are looking at this with a very serious, highly clinical lens.
We have to. We are addressing life or death preventative medicine today. There's no room for humor or casual banter when we are talking about a disease claiming this many lives.
Absolutely. So, to really understand the sheer urgency of the 2026 ACS guidelines, we first have to confront the epidemiological reality.
Right, the mortality data, which is alarming.
It is deeply alarming.
Yeah.
Looking at the 2026 ACS data, colorectal cancer is now the #2 leading cause of cancer death across all age groups in the United States.
#2 overall.
Yes. But here is the statistic that represents a true emergency. It is now officially the #1 top killer for adults under 50.
The #1 cause of cancer death for that demographic.
Exactly. And we are seeing these rates steadily increasing in adults under 65 across the board.
And that represents a profound shift. Historically, in the medical community, we viewed CRC as a disease of advanced age.
Right. Something you worry about much later in life.
Precisely. The fact that it is now the primary oncological killer of younger adults is a massive structural failure. But what makes this a cruel clinical paradox is that colorectal cancer is highly treatable.
Highly treatable. I mean, if it is detected in its early stages, it is often entirely curable.
It is. So the root cause of these fatalities is not a lack of treatment efficacy. The root cause is a catastrophic lack of compliance.
Which brings us to the gap. The data shows that 50 million eligible Americans remain unscreened.
50 million. It is almost incomprehensible.
It is. And as a direct consequence of that gap, 3 out of 4 colorectal cancer deaths occur among patients who are simply not up to date with their screening protocols.
3 out of 4.
Right. So, we have to question the structural failure of the medical community here. How did we fail to achieve compliance?
Well, we have historically relied on a system that creates extreme friction for the patient.
I compare it to a clinical blockade. Because if you look at traditional screening requirements, they are incredibly demanding.
The visual colonoscopy has been the gold standard.
Yes, but the extreme inconvenience of traditional colonoscopies acts as a systemic barrier. I mean, you have the intensive bowel prep, which is physically miserable.
Right, and the mandatory fasting.
The fasting, the need for sedation, which means you require time off work and you need a designated driver. You can't just go about your day.
Exactly. And for many populations, taking 2 days off work is a financial impossibility.
And then even with the alternatives like the stool-based tests, there is a highly unpleasant perception associated with them.
Yes, the handling of the sample. Patients actively avoid it.
So these logistical and behavioral hurdles are literally preventing life-saving detection. Which brings us to the second segment of our analysis.
The 2026 ACS guideline shift.
Right. Because traditional structural barriers are failing those 50 million Americans, the American Cancer Society had to fundamentally revise its clinical strategy.
They had to prioritize behavioral realities. Theoretical clinical perfection doesn't save lives if the patient refuses the procedure.
Exactly. So the major revision here, the ACS now officially recommends that regular screening begin at age 45 for all average-risk individuals.
Dropping the age is critical. It places a heavy, deliberate emphasis on that younger demographic, the 45 to 55 range.
And also on historically minoritized groups who are disproportionately impacted by those structural barriers we just mentioned.
Yes. And to enforce this, the ACS issued a profound mandate. They stated the most effective screening test is the one that the patient completes.
The most effective screening test is the one that the patient completes. That is a massive paradigm shift for the medical community.
It truly is. It changes the entire strategic approach.
I mean, for decades, we demanded patients undergo the most invasive procedure first.
Right. And now the strategy has officially shifted. The guidelines officially expanded options to include new blood-based and at-home tests.
Meeting the patient where they are.
Precisely. The goal is to simply get them into the screening pipeline by any scientifically validated means necessary.
Which perfectly sets the stage for the technology that makes this behavioral shift possible. The science of liquid biopsy.
This is where we see a major technological leap.
Right. The presentation highlights the integration of blood-based screening, specifically introducing the Shield blood test by Guardant Health.
Which is a remarkable advancement.
It is the first and only FDA-approved blood test for primary colorectal cancer screening in average-risk adults.
And we must define average risk very clearly here.
Please do.
This is for individuals with no prior history of CRC, no history of precancerous polyps, and no inflammatory bowel disease.
Okay, so strictly average-risk patients. And this test is now officially recognized in both the ACS and the NCCN guidelines.
Yes, the National Comprehensive Cancer Network, having that institutional backing is monumental.
So let's break down the actual methodology of how this liquid biopsy works. There are 4 distinct steps outlined in the source. Step 1 is simply a blood draw.
A standard venipuncture.
Right. Completed seamlessly during a routine doctor's visit, alongside your standard lab work.
And crucially, it requires no fasting and no special preparation.
Which immediately removes the clinical blockade we discussed earlier.
Exactly. Then we move to step 2, which is the DNA analysis.
The actual liquid biopsy phase.
Yes. This advanced technology scans the patient's blood sample for circulating tumor DNA. We refer to this as ctDNA.
And ctDNA, just to be clear, these are microscopic fragments shed by tumors directly into the bloodstream.
Precisely. As tumor cells undergo apoptosis or necrosis, they degrade and release their genetic material into the blood.
So the machine is looking for those fragments, which leads to step 3, signal detection.
Right. The assay utilizes highly sensitive, highly calibrated mechanisms
To identify specific genomic alterations.
Yes, it isolates the exact molecular signatures that are intrinsically associated with colorectal cancer.
It's an incredibly targeted molecular search. But this brings us to step 4, actionable results. And I want to raise a very critical clinical caveat here for the listener.
It is imperative we clarify this.
This Shield blood test is a primary screening tool. It is not a standalone diagnostic endgame.
Right. It cannot formally diagnose the cancer on its own.
A positive blood test result must be followed by a mandatory diagnostic colonoscopy
It absolutely must.
to physically confirm the findings and to remove the potential polyps.
Exactly. The liquid biopsy detects the molecular signal that a malignancy is developing. But the gastroenterologist still has to go in visually to find the specific lesion and excise it.
So it serves as a highly advanced radar system. It tells you if you actually need to undergo the invasive procedure.
Precisely. It reserves the colonoscopy for those who actively have a molecular indication of disease.
But, a test is only as good as its clinical efficacy and the actual willingness of the public to take it.
Which brings us to the clinical data driving this approval.
Right. Segment 4 of our analysis. Let's look at the Eclipse clinical study, which was published in the New England Journal of Medicine.
The NEJM. It is a highly rigorous, peer-reviewed source.
And the data from that trial demonstrated 100% sensitivity for stage 2 and higher colorectal cancer.
100% sensitivity.
That is an incredible clinical metric.
Mm.
It means it did not miss a single case of cancer that had progressed to stage 2 or beyond in that study cohort.
Correct. It successfully identified those critical yet still highly treatable stages of malignancy.
But as we've noted, laboratory sensitivity means nothing without patient adherence. And this is the adherence breakthrough that the presentation emphasizes.
This is the most critical metric of the entire discussion.
Real-world data from approximately 200,000 patients. The screening completion rate for the Shield blood test is greater than 90%.
Greater than 90% completion.
I mean, when you contrast that with traditional methods, the numbers are staggering.
They are. Stool-based tests sit at roughly a 45% adherence rate.
And traditional colonoscopies are at a dismal 38% for initial screening.
Right. So we are looking at an intervention that shifts participation from 38% up to over 90%.
It completely bridges that 50 million person gap.
It does. And the recommended interval for this blood-based test is every 3 years.
Every 3 years. And its primary clinical use case is exactly for those individuals who actively decline visual exams or who have repeatedly failed to complete the stool tests.
It is designed specifically for the non-compliant population.
The public health impact of this cannot be overstated. By removing the need for intensive preparation and time off work, it massively reduces barriers.
It directly combats systemic health inequities.
Yes, specifically for racial, ethnic, and lower socioeconomic populations who cannot afford the logistical burden of traditional screening.
By offering a highly sensitive blood draw during a standard checkup, we are democratizing access to preventative oncology.
We are entirely shifting the epidemiological trajectory of this disease.
We are. And as we conclude our analysis of these 2026 ACS guidelines, I want to offer a final, highly provocative thought for the listener to consider.
Please, go ahead.
We are witnessing a momentous leap in precision oncology today. If molecular-level liquid biopsies can successfully shift colorectal cancer screening from an avoided invasive procedure to a simple routine blood draw, we have to look toward the horizon.
Broader implications.
Exactly. How might this liquid biopsy technology soon revolutionize our entire approach to pan-cancer detection?
Pan-cancer detection, meaning a single blood test for multiple malignancies.
Yes. We are fundamentally shifting modern medicine from reactive treatments of late-stage disease toward proactive, completely non-invasive prevention.
It is an incredible medical frontier. But returning to the immediate clinical reality, our directive to you is clear and urgent. Screening saves lives.
It unequivocally saves lives.
We urge you to speak directly with your physician about the screening option that is appropriate for your specific health profile. Do not become a statistic of non-compliance.
Get screened.
You are watching to the Dr. MEK Explainer Series.
You are watching to the Dr. MEK Explainer Series.
Thank you for your time today. Please subscribe and hit the bell for updates on future medical discussions.